Right now we're going to parasympathetic, and to be honest, neither one of these have shown up on your test. But I wanted you to know that there was a parasympathetic disorder spot, so I just threw in Sjogren's and gastric paresis. Gastric paresis is accompanying some autoimmune diseases, some bariatric surgery problems. So at least you know of it. You know Sjogren's, how dry I am, you can't swallow. But again, not a big player on your test. So you can put a light X through there, but there is such a thing as parasympathetic disorders. So Horner's is a sympathetic disorder, okay? Horner's. Now, when we talk about vertigo, I put all the dizzies here now. So they're all here, didn't keep any out. So I want you to look at this list and I want you to tell me which one is never related to trauma. And that is, of course, no trauma Meniere's. So if somebody's dizzy, we're going to ask, have you had trauma? If they say, no, doctor, I haven't had any trauma, then you say, hey, do you have ringing in your ears? Do you ever have transient deafness? And pretty much, you know, you've got your Meniere's case, which we call sensory neural deficit. In case you don't know, it's sensory neural, it's cranial nerve 8, okay? And yes, you can adjust this patient. You know, and I want you really to give it a good old college try. And there's some good nutritional things out there you can do. And there's new ones always popping up and on the market. So really try the very best you can, because the sedatives they give usually don't work. And then the patient complains and they usually end up having surgery. And it's kind of, I've had a couple of really good surgeons explain to me that you really get in there and it's kind of like there's a green wire and a red wire and you never know for sure which one to clip. And if you clip the wrong one, they go deaf. But they say, hey, they got 2 ears, so at least it doesn't ring in this ear anymore. So you know what I mean? I mean, who wants to have that problem? So I want you to realize you really have a pretty good track record of helping quite a few of these. So give it your best shot, do some homework, make sure you don't give up too early. Now, when we talk about benign positional vertigo, it does have the name benign paroxysmal positional vertigo, and that paroxysmal is the giveaway because that's what's telling us that little piece of debris, that little stone that's in there, kind of gets trapped in a new place every time, which makes it unpredictable. So sometimes it's when you turn to the right, sometimes turn to the left, sometimes up, because it's always in a new spot, so it gets dislodged with a different motion. But we can adjust this patient. The whole idea is to take them through kind of a real, it's kind of an invasive, kind of aggressive motion to try to get that thing lodged at the base. The good news is usually the stones resorb, okay, over a period of time, depending on the size, how long it takes. But the problem is if you make one stone, you make another. So that's the problem. They usually are a stone former, so they might have another. Now, Wallenberg, going to be referred out. That's the person kind of having symptoms of almost a stroke after trauma. Barry-Lou is the rotation, so you can adjust them as long as you don't rotate. Labyrinthitis, as long as we've ruled out infection. If it's just a little swollen labyrinth, it's not a big deal. You can adjust. Now, motor only, I had 5 in your Part 2 book, and I think I stuck to that 5 in your Part 3 book. I might have wheedled it down to 4, but now there are 3 big ones that really you need to know, okay? Myasthenia gravis will not have any numbness or any kind of sensory loss. So myasthenia gravis, usually on the face, is just some muscle weakness, double vision, trouble swallowing, chewing, okay? It's muscle weakness on the face that's relieved by a nap. Okay, it's a problem with the neurotransmitter right here at the bioneural junction. And they can't, you know, they keep attacking this area, and it's an autoimmune attack. Have I got autoimmune up there somewhere? Okay, autoimmune attack. And the medical community will cut their thymus out. That weakens their immune system so they don't attack it. Okay, so that works, but it's, you know, pretty aggressive. And really when you take your thymus out, it's sort of the director to your immune system. So your immune system is kind of as healthy as your thymus is intact. So it's pretty aggressive to do that, but at any rate, you can adjust them. Let's hope you can make a difference. It is a slow descending paralysis, so the good news is it very rarely gets into cranial nerve 10, even though it does the muscles that are the motor muscles of the cranial nerves, and that's a good thing because it would get into your heart and lungs, and then you would very quickly die. All right, now ALS, amyotrophic. I don't have good growth of muscle, lateral sclerosis that affects my central nervous system. Okay, so upper motor neuron lesions cause spastic paralysis. Lower, a lack of muscle is going to be a lack of muscles, lower motor neuron lesions. So it is upper and lower motor neuron lesions. Really, I probably should have said lower and upper so that lower was below that and upper was below that, but it's a good test for you to see if you get it right. It starts in your hands. So they might not have good coordination with the ketchup bottle or the mouse or opening a door or writing their name, so they'll start to complain of those things. Okay, the final phase will be when they can't swallow or chew. That's your bulbar palsy. And of course, everybody's doing anything they can, because within 3 to 5 years they could be dead. Some people seem to linger on quite a lot longer. Maybe it's because of nutritional things, maybe it's because of good adjusting. I don't know that we really know, but bracing is going to be necessary as they lose their motor control, so you and the orthopedist are going to keep them mobile as long as you can, as well as the neurologist keeping track of what's happening. Now, Parkinson's is the start-stop problem, okay? So start-stop issues is what we have. So the questions are, do you have trouble initiation motion? You know, initiating motion. Is it hard to begin walking, hard to get up out of the chair, hard to start to speak, you know, hard to start to get that first bite of soup? And then once you get that first bite of soup, is it hard to stop? When you walk, is it hard to stop? We call that festinating or propulsion. So those are the two questions that we ask. The one thing that they lose very quickly, I think it's up here, dependent arms, is they'll walk without an arm swing. So their arms are just kind of held there so they can get their legs moving, but it's just way beyond the peril to get their arms moving as well. Well, we can co-manage them, so we can be taking care of them. Some get more resting tremors than others, so there are some surgeries and drugs that can help with the different signs and symptoms of this dopamine shuttle problem in the basal ganglia. Now, the anything disease kind of include the stroke, the tumor, the MS, the infection, and cord compression. Because these can start with emotional problems or motor problems or sensory problems. But let me ask you this. Without even looking at that list, if I kind of stand in front of it, what if I told you somebody had slurred speech at the breakfast table started this morning? See, you'd think right away stroke, okay, because of the way I presented it. If somebody's running a fever, you're going to go right to infection. If I've said they've had several episodes of this, it kind of comes and goes, probably your first thought was MS. All right, now I want you to tell me what two up here do you think are aggravated by neck flexion pretty predictably? Like 99.9%. Okay, now I'm hoping your first answer was infection. If there's infection in the central nervous system, it usually puts pressure on the meninges, and the meninge tests are Brzezinski and Koenig's, which are both based on flexing, right? Flexing to put tension on the meninges. So I'm really hoping that your meningitis, encephalitis, your infections was one of your top answers. Probably the second answer I would put is cord compression, because the majority of it's in the cervical spine. We know it's going to hurt ADI instability as well as the degeneration of the lower cord. So cord compression is exacerbated by flexion. Now, the tumor depends on it. If it's up here in the front, you know, flexion isn't necessarily going to bother it. You know, so a stroke isn't usually bothered by neck flexion. So I hope at MS, I know some of you went to Lermitz, didn't you? But Lermitz, they may have all their problems down in the lumbar spine, or it might be, you know, deeper into the central nervous system. So MS is not necessarily going to have a problem with cord compression. So I hope you you understand now that infection and cord compression are the two predictable.